This manuscript describes the sensitivity of cerebral near-infrared spectroscopy measurements to detect low cerebral venous oxyhemoglobin saturations in infants undergoing the Stage 1 procedure. Following the Stage 1, or Norwood procedure, blood flow to the body and to the lungs exists in parallel. Following this operation, oxygen delivery to the brain and other organs can be compromised by a number of factors, including diminished cardiac output, diminished systemic blood flow due to elevated systemic vascular resistance, arterial hypoxemia, and others. Screening for insufficient oxygen delivery is commonly performed through assessment of the venous oxyhemoglobin saturation. Because assessment of a true mixed venous saturation is anatomically precluded in the single ventricle circulation, most providers utilize a cerebral venous saturation, or at least blood sampled from the superior vena cava, as it has been proposed that an SVC oxyhemoglobin saturation below 30% represents the anaerobic threshold. Let's examine this in more detail on a cellular level. Molecular oxygen is carried primarily on erythrocytes to tissues, such as the brain, by continuous blood flow. Oxygen is in turn continuously consumed by the mitochondrion, where it serves as the terminal electron acceptor in the electron transport chain, reducing oxygen to water. This creates a diffusion gradient for molecular oxygen from the capillary to the mitochondrion, a gradient that is always in flux. If oxygen consumption decreases, as it does during hypothermia, the composite oxygen tension in the cells of the brain, or tissue PO2, increases. Alternatively, as oxygen delivery slows down, as is the case during low cardiac output, decreased systemic blood flow, or arterial hypoxemia, or other reasons, the average oxygen tension in the cells of the brain decreases. This increases the driving gradient for oxygen to dissociate from hemoglobin within the blood vessels, reducing the fraction of hemoglobin molecules which still have oxygen bound in the veins, or SVO2. So the purest way to monitor the adequacy of cerebral oxygen delivery would be to measure cerebral tissue PO2, which is done in traumatic brain injury but is not used in newborns for a variety of reasons. Relying on the SVO2 of cerebral venous blood is the next best surrogate, but requires repeated phlebotomy and has other challenges. So many centers frequently rely on cerebral near-infrared spectroscopy as a surrogate to identify patients with low SVC saturations. Similar to the technology used to measure SVO2 in a blood gas, NIRS technology uses absorbent spectroscopy to measure the composite oxyhemoglobin saturation signal in a tissue. Unlike a blood gas, though, which is drawn from either an artery or a vein, the probe samples hemoglobin present in a number of sites, arteries, capillaries, and veins, and in a number of tissues, skin, skull bone, and brain. Although it is not intended to be used as a surrogate for SVO2, NIRS monitoring is often interpreted in that way. In this study, we examined the sensitivity and specificity of the NIRS monitor applied to the brain to detect a critically low SVO2, below 30%. We found that in all patients with an SVO2 less than 30%, the NIRS value was never less than 30, and was less than 40 only 1% of the time, and was less than 50 only 46% of the time. Unfortunately, a NIRS value of 50 approaches the clinically normal range, making it a poor screening tool. When cerebral NIRS was low, however, we found it to be specific for a low SVO2. We hypothesized that mathematical removal of the arterial component of the NIRS signal would improve the sensitivity of the NIRS device to detect low SVO2. As shown in the dotted line, when SVO2 was less than 30, the mathematically corrected RSO2 or NIRS value was less than 30 6.5% of the time, less than 40 29% of the time, and less than 50 77% of the time. It is important to note that we tested only a single version of a single device, and algorithm detection is always improving. Our study took place in the ICU, and the results do not apply to other environments, such as the operating room, in which cerebral NIRS has been extremely well validated as a predictive screening tool. We also note that many centers have reported that multi-site monitoring, such as on both the brain and the flank, has accurately predicted low oxygen delivery states in the intensive care settings. So we would only conclude that a cerebral NIRS value in the normal range, at least in isolation, should not be considered reassuring, as it is insensitive to detect low SVO2 states following the stage 1 palliation.